So on behalf of HealthCert Education, I'd like to welcome you to this evening's webinar. This is the third webinar in a series aimed at bringing value to our alumni by providing clinical guidelines updates and new information easily and concisely with a wonderful presenter who shares relatable and interesting cases. We've been impressed so far by the number of people registering for these webinars, and tonight over 700 GPs and healthcare practitioners have registered. As you would have seen, this webinar focuses on understanding the updated clinical guidelines for contraception. This webinar and Q&A will provide valuable insights into the recent updates to the primary care clinical guidelines for contraception and help you to make evidence-based, patient-centered treatment decisions. Now, before we get started, I'll run through some housekeeping and introductions. At the end of the webinar, we have a post-webinar survey that provides you with the opportunity to give feedback on the webinar and request more information on any of our courses that might help you in your CPD journey or to subspecialize in a particular area of interest in your practice. The webinar is being recorded. Please feel free to share that with any colleagues who may find it of interest. And for those of you attending live or watching the recording, you may be able to apply for CPD for this webinar. A certificate of attendance will be emailed out with the recording, along with some instructions on how to self-submit to your relevant college for consideration of CPD. And with that, let me introduce Dr. Simone Gonzo properly. Dr. Simone began working in healthcare as a registered nurse in hospitals throughout Queensland in 2003. After changing to medicine, she graduated with an MBBS from the University of Queensland in 2010 and gained fellowship with the RACGP in 2015. Dr. Gonzo enjoys all aspects of general practice, including family health, mental health, chronic disease management, and complex primary care. She also has a special interest in teaching and training GP registrars and medical students. Dr. Gonzo champions general practice and promotes its importance in the healthcare landscape and is currently working on a Master of Healthcare Leadership. And with that, I'll invite Dr. Gonzo to get the presentation underway. Over to you.
Thanks, Campbell, very much for that great introduction. Welcome everybody tonight. As you can see, we're talking about contraception. So firstly, I'd like to start with our acknowledgement of country. I'm in Caboolture, which is Gubbi Gubbi country, so I'm recognising the traditional custodians of the land, connection to land, waterways and community, paying respects to elders past and present. So Campbell has already spoken a little bit about myself and my background. Tonight what we'll be learning about is the new contraception guidelines. You can see on the slide there, that's just the front page of it. It's a fairly content-heavy webinar, and it might seem like we're flying through the slides. A lot of the slides are just an example of what information is available for you to access. So it's just to highlight different areas. We'll be applying the guidelines to a patient case and following that patient through her life cycle, life stages of life, to see how we can apply this new knowledge that we've gained. So in regards to the overview of the guidelines, it was developed by the CGuide3 development group, and it's been approved by Women's Health Committee and College Council in July 24. The Faculty of Sexual and Reproductive Healthcare is a multidisciplinary professional membership organisation based in the UK. They set clinical guidance and standards, providing training and lifelong education, and champion safe and effective sexual and reproduction healthcare across the life course. This particular guideline is based on or developed from one that was originally developed in 1991. The current version is the one we'll be chatting about tonight, and then it's for review in another 5 years. So the objectives of this guideline, it's a signposting format. So it's providing direction to evidence-based guidance and good practice points. And it does not provide any specific contraceptive advice for transgender and gender diverse people. There are other resources that are available for those populations, and that's covered elsewhere. We just simply don't really have the time tonight to go through. You'll see that we've got a lot to cover as it is. With regards to the methodology of a signposting guideline, we're not reinventing the wheel. Each contraceptive method has levels of evidence and resources related to that contraceptive method, so it can be read in isolation. So it's a collection of reliable sourced information that you can read in isolation with regard to that particular form of contraception. You don't need to read the whole guideline from beginning to end. It is designed to just pick it up and read a chapter and find the bit that you need at the time. And it's high quality evidence. Each guideline has its own level of evidence listed as well. So tonight, what we will be covering is, you can see there the 10 different points there, running through all of those. I won't read them all out, but we'll go through and we'll get quite familiar with throwing around a few terms and looking at different ways of using things, different combinations and applications. What is not covered in the webinar, and that's just basically due to time, is those specific populations. However, in saying that, there is some overlap with what we'll be talking about in terms of after pregnancy, young people over 40, obesity and overweight. That does feature in most of the contraception options as well. The previous guidelines, the old book that some of us may remember, especially here in Australia, was based in 2012. So I was still rely on this book up until I realized that we had a new edition of that. I had tried to purchase an updated one, contacted the family planning, and they directed me to this particular edition, which is a 4th edition. And you can see there that it's actually out of print. When you click on that, it sends you off to the therapeutic guidelines, which is still a good source. However, it's not very specific to contraception. So these guidelines that we'll be chatting about tonight are quite well overdue. So we'll crack on and we'll look at, firstly tonight, combined hormonal contraception. So this is the combined pill, the OCP. And that covers combining daily estrogen and progestogen. The recommendations generally refer to low dose CHC, which is less than 35 micrograms of the estradiol. You can run it as tailored extended CHC regimes. So that is continuous cycling, where you actually skip a period and you just run on through with that. In general, most of the time you can do that for up to 3 months, 3 periods, and then you'll end up probably having some breakthrough bleeding. And then it's recommended just to stop and have your period with that. Also in this, the guidelines have included the vaginal ring. It is available in Australia, not so commonly used, and I don't think it's on PBS. So you basically insert the vaginal ring for 3 weeks, take it out, and then you have your period, put a new one in. So I think you get a box of 3 of those when you have your script. When do we start the combined hormonal contraceptive pill? On day 1 to 5 of the menstrual cycle. We talk about medically eligible women, so that's just a term that the guidelines refer to for people that don't have any contraindications. So we'll get to the contraindications as we work through. But we start on day 1 to 5 of the menstrual cycle so that we can be assured that there's no pregnancy and that we don't need any additional contraceptive protection. You can quick start the pill at other times. You can do that within 7 days using additional contraceptive precautions if you're reasonably certain that we don't have a pregnancy, or a pregnancy test is negative, which is just a urine test. And we'd also like to follow that up with a repeat urine test at 21 days, which is your 3 weeks, to make sure that we haven't missed a very early pregnancy. So with regards to the pill and obesity and bariatric surgery, so these 2 statements may seem a little bit contradictory, but most evidence suggests no association between weight and body mass index, or BMI, and the effectiveness of the combined hormonal contraceptive. So we don't need to double the dose or anything like that to achieve protection. The flip side of that is that women who have had bariatric surgery must be advised that sometimes the effectiveness of the pill may be reduced, and that's down to absorption, just the altered absorption, metabolism of the medication. Interactions. So the effectiveness can be reduced during the use of enzyme-inducing drugs and for 28 days after stopping those drugs, which was something that I found interesting while putting this together. So examples of those medications are classes of antibiotics, anti-seizure medications, and antiretrovirals. So they're quite specialized medications, really. And hopefully patients won't be on them for, too long, but still it's something to consider. And alternative options would be to offer reliable contraceptive methods that are unaffected by those medications. Lamotrigine and the pill also may reduce seizure control or cause lamotrigine toxicity. So that's another special case that will that we need to take into consideration. In that case, the pill may outweigh the risks of the pill may outweigh benefits in those cases. So you may want to look at other options or seek specialist input with that. In terms of how do we manage those interactions, additional contraceptive precautions are not required when used with non-enzyme inducing antibiotics. Also, after using the emergency contraceptive pill, there's two of those that we'll cover later. One of them is ulipristal acetate for emergency contraception. We must wait 5 days before starting the combined hormonal contraceptive pill with that. During that time that we're waiting the 5 days, we need to use other precautions to make sure that we don't have a pregnancy that's unintended. Health benefits of the pill. It can reduce heavy menstrual bleeding, can improve pain, improve symptoms of premenstrual syndrome and acne, endometriosis management. The continuous regimes for tricycline, 3 months, can lower the risk of recurrence of endometriosis after surgery. In PCOS, it can help manage acne, hirsutism, and menstrual irregularities, so we can make our periods more regular and predictable. There's also some evidence that it can induce cancer risk, reducing the risk of ovarian and endometrial cancer, and that protection can last for decades after stopping the pill. It's also associated with the reduced risk of colorectal cancer. The important thing that everyone always needs to think about with the pill is vascular risks. So venous thromboembolism, there is an increased risk. It varies by the progestogen type and estrogen dose. The absolute risk remains very small though, but it is still very important to screen those patients for their contraindications, which I'll point you to a good resource to work that out as we work through. Cardiovascular events, very small increased risk of myocardial infarction and ischemic stroke, higher with higher estrogen doses. However, they're still very extremely rare cases. Breast cancer, there's a small increased risk, but that risk reduces over time after stopping the pill. And cervical cancer, there's a slight increased risk with use for more than 5 years, and that reduces over time as well. Now, in terms of the vascular VTE risk, if it is too much of a higher risk, we need to strongly caution the patients and avoid the pill. Once again, that comes with your shared decision making. Common risk factors for arterial disease include smoking, past or family history, and a high BMI. The length of use and perimenopause. This was something that came up a fair bit in the pre-webinar questions. So our length of use before major surgery or limited mobility, it's always good to think about just the daily life, because we think the pill's just something that we take all the time over 30 years or whatever it is through a reproductive phase. Before major surgery or limited mobility, the guidelines do advise to stop the pill at least 4 weeks prior and switch to an alternative contraceptive method. And it can be used for medically eligible women for contraception until age 50, also providing some relief of menopausal symptoms, preventing bone density loss, and providing effective contraception up until age 50. In practice, some gynecologists can use it longer or advise that you can use it for longer. However, the guidelines do state until age 50, and then we need to think about another option for risks. Now, moving on to those risks, I'm not sure this is one of those busy slides, but are you probably all familiar with the UK MEC that we use in terms of our risk factors? And you can see there that there's numbers that we say puts a patient at a higher risk. So each characteristic, and then we've got the UK MEC going down to UK MEC 4 is a condition which represents unacceptable health risk if the method is used. So we steer clear of the UK MEC, and you can just have a quick look at that one. Cigarettes, BMI, all add up to having a higher MEC. We like to stay around basically UK MEC 1 and 2. And that'll feature through the information so that you can see it kind of gets a little bit closer to comparing the same for same. So moving on to our next contraceptive option, which is our intrauterine contraception. So commonly known as, in Australia here, we have Mirenas, Kylenas now, and we also have copper IUDs. These are both T-shaped devices. The copper IUD is made of plastic and copper. Both of them are placed inside the uterus or into the uterus. The copper IUD does not have any hormone. It's quite difficult to get in Australia, and I think it's quite expensive. To access the copper IUD, I am fairly sure you have to go to family planning. I have tried to prescribe it on PBS, but the chemist wasn't able to actually access it. So I'm not sure if anyone else has any better luck with that. Your typical Mirena has a couple of different variants. We've now got the smaller Kylena that we can use in Australia, and it sounds like in New Zealand you guys have got the Jade S. And the duration of effectiveness varies by dose in terms of the Mirena. So on the next slide, you can see there's comparing the size of the intrauterine device, so 52 and 19. Now, one of the updates is that we can use the Mirena for 8 years. It can be left in situ for 8 years, and the larger copper IUDs can stay for 10 years. So in terms of benefits of this form of contraception, we've got the Mirena manages heavy menstrual bleeding and dysmenorrhea, so giving the regularity back. Can also be used for endometrial protection as part of hormone replacement therapy for up to 5 years. That's something to note, is that it's still only available for the 5 years for endometrial protection. It has to be longer than that. If you want to keep using it for HRT for endometrial protection, we have to change over the Mirena device. So yeah, can be used for, if it's inserted after age 45, it can be used for contraception until age 55, taking into account that we're probably perimenopausal in that time. Copper IUDs, they're a really good option for emergency contraception. Inserted at age greater than 40 years, can be used until menopause and then removed 1 year after the final menstrual period. Inclusivity of intrauterine, it's great for young individuals, those who've never been pregnant, and those who've never been sexually active. So we can still use it for those individuals as well. And after pregnancy, we've got a really good option of using the IUD postpartum within 48 hours. Safe, effective, and convenient, high continuation rates. It does require specialized insertion techniques, so generally in the hospital setting. And however, between 48 hours and 4 weeks, it's not recommended. There's an increased risk of uterine perforation, especially if breastfeeding, that increases that risk. Inserted after 28 days, the risk of uterine perforation is small, but still remains higher if breastfeeding. There is a higher expulsion rate when it's inserted within the 48 hours compared to later on postpartum and or after a vaginal birth compared to a cesarean birth. However, it's still an option, especially if you're sort of remote and difficult to get patients in. It just gives them a good option to at least try having the Mirena inserted before they leave hospital. The benefits of having a Mirena inserted post-abortion: it's convenient and acceptable. with high continuation rates. It's associated with a reduced likelihood of another abortion within 2 years. After medical abortion or a miscarriage, which is a medical expectant management, it can be inserted anytime after expulsion of the pregnancy. You do need to make sure that we have ensured there's no retained products, sepsis, or new risk of pregnancy. So they're the three things we need to be clear about, that we have excluded another pregnancy, infection, and retained products. The intrauterine device can be inserted immediately, provided there's no suspicion of sepsis after a surgical abortion or surgical management. Uterine malformations. So the risk generally outweighs the benefits for individuals with known cavity distortion. This is an individualized decision-making process. So basically, factors to be considered include the degree of distortion, the accuracy of the imaging indication, and potential consequences of complications. So that would be more into the specialist side, gynecological or the hospital setting, where the patient may be considering having a Mirena or IUD inserted with a uterine malformation. And yes, we're probably better placed with a hysteroscopy for guidance there, or ultrasound. So risk of infection, insertion contraindications. So providing we don't have any concurrent PID, postpartum or post-abortion sepsis, gonorrhea, chlamydia, we can go ahead and put our Mirena in. And if we need to delay insertion, it's wise to offer some bridging contraception until the infection is resolved and we can place our IUD. Cardiac disease, postural orthostatic tachycardia syndrome, so quite making its presence known amongst that younger female population. It's generally straightforward and low risk if precautions are followed, such as adequate hydration, salt intake, and postural awareness. So patients can have a tachycardia, drop their blood pressure, and that's why we just want to make sure their hydration, salt intake is adequate. Cardiac disease, you'd want the cardiologist to be on board with that, just to make sure that it's okay to have the IUD inserted. And obviously, if there's pre-existing arrhythmias, other long QT syndromes, the problem is the vasovagal reaction during the IUD insertion that could pose the risks, and that's why it should be done in a hospital setting. So there are other things that we would need to think about. Health risks with an IUD. There's a possible association between current or recent use of hormonal contraception and including the IUDs, and a small increase in risk of breast cancer. The overall absolute risk remains very small. And although the incidence of ovarian cysts might be elevated during Mirena use, it doesn't appear to be clinically significant. The presence of or existing presence of cysts or PCOS is not a contraindication to Mirena use. There's limited evidence to suggest that the IUD has no significant effect on serum estradiol levels or bone density as well. In terms of bleeding pattern, copper IUD is not so favorable. You can have an increased menstrual loss initially, and compared to natural cycles, the increased bleeding often decreases over time. It does take a little bit longer. With the levonorgestrel IUD, altered bleeding patterns are common initially. So often patients will have, even with the Mirena, they have a little book to mark down how things are going for them. However, there's a trend towards decreased bleeding over time with continued use, which is pretty much what we see in practice anyway. And it can range from having no periods to very regular light monthly cycles, and that's about it. Occasionally, some patients do have heavy menstrual bleeding, and that's a complication that we need to deal with and manage it as it comes up. So with if we do run into those that heavy menstrual bleeding, you can use some tranexamic acid or NSAIDs to manage the symptoms of that. And you can also use the pill, the CHC, for a 3-month trial to see if that manages the symptoms while we're waiting for the Mirena to settle down a little bit there. If we happen to have a pregnancy with an IUD in situ, there's a very low risk of pregnancy, including an ectopic with an IUD use or a copper for emergency contraception. Ectopic pregnancies, if pregnancies occur with a Mirena, the likelihood of ectopic pregnancy is higher than without an IUD. However, a previous ectopic pregnancy is not a contraindication for IUD use. A positive pregnancy test with an IUD in situ basically needs referral to your early pregnancy unit. So yeah, we will be sending them up to the maternity with shared decision making. We want to confirm where that pregnancy is located to make sure it's not an ectopic. So generally they'd be off for a fairly prompt ultrasound to confirm if we have an intrauterine pregnancy or an ectopic pregnancy. Under 12 weeks, if we do have an intrauterine pregnancy with an IUD in situ, if we can see the threads, we would be removing the IUD because it can improve the pregnancy outcomes later on. In terms of post-insertion infection, there's a slight increase in pelvic infection risk in the first 3 weeks after IUD insertion. It's still less than 1%. There's also a risk of vulvovaginal candidiasis or bacterial vaginosis with IUD use. It's limited and conflicting evidence there. But one thing to just be aware of is pelvic actinomycosis. It's a rare chronic bacterial infection linked to long-term IUD use. So if we do think that we have an infection post-insertion, we don't have to rush to remove the IUD straight away. If it's a mild to moderate PID, the Mirena can remain if clinical improvement occurs within 48 to 72 hours of antibiotics. We would be following our local guidelines and reviewing after 48 to 72 hours. Generally, you'd follow the therapeutic guidelines that we discussed earlier in the webinar. That's a great resource for looking at which antibiotics to use. You can also possibly have a chat to your gynecological registrar, but I find the therapeutic guidelines are just as useful. If there's clinical non-improvement after that 48, 72 hours, we probably need to look at removing that Mirena, assessing the pregnancy risk if we've had unprotected intercourse in the last 7 days, because the Mirena may not have been as effective with an infection in the environment, and we'd possibly be considering whether or not we need emergency contraception and follow-up pregnancy testing as well, depending on that timing. Expulsion. It's a 5% risk, approximately 5% risk of expulsion over 5 years. Most common in the first year, particularly within the first 3 months of insertion, and also postpartum. So we've discussed about postpartum and how that is a higher risk. So immediately postpartum versus interval postpartum or individuals with no recent pregnancy, it's a higher expulsion rate. Increased risk factors for an expulsion of an IUD in adolescents, post-late first trimester or second trimester surgical abortions, individuals with fibroids, heavy menstrual bleeding. Interestingly, concurrent use of a menstrual cup, I hadn't realised that was an increased risk factor. And if the patient has had previous IUD expulsions, there's an increased risk. If the patient has had more than 2, we'd be considering a pelvic ultrasound to assess the cavity before the next reinsertion if they still wanted to have it, and possibly placing that next Mirena in with a hysteroscopy or ultrasound just to make sure that it's located correctly. A post-insertion ultrasound scan, so ultrasound after we've put the Mirena in, it's not predictive of future expulsions. All it really does is confirms that we've got correct positioning at the time. Now, perforation is the other risk factor that we would be, that's also, sometimes in the news. Very low overall risk, 1 to 2 per 1,000 insertions. Higher risk with postpartum interval insertion. especially greater than 48 hours after childbirth. So that's where we would be wanting to keep our insertion away from that after 48 hours time frame. Indicators of a perforation: lower abdominal pain, threads that aren't visible, and changes in bleeding patterns. So what do we do if we think we've got a perforation? Immediately perform an ultrasound. Pelvic X-ray is still okay because they're radiolucent. You can see the little device on X-ray. Consider emergency contraception, pregnancy testing, and to ensure then make a plan for ongoing contraception as well. And if there is a confirmed or suspected perforation, and we can exclude the device from still being in the cavity, and we know that it's not in the abdomen as well, we'd wait 6 weeks before reinserting it, and also be referring to specialist services with ultrasound so that it can be placed safely. In summary, for IUDs, you can see this is another busy slide, and basically we've got just the UK MEC on the left-hand side. On the right-hand side, there is a little flow chart that tells us what to do or explains if the threads aren't visible. So you can follow that all through, and that's all in the guidelines that we can see. So moving through to our progestogen only pill, which is the mini pill. So we've got a couple of different options on this one. There's lots of different brands coming onto the market all the time. Traditionally, we use the norethisterone. Now, that is classed as missed if it's more than 3 hours late. So we want that to be taken every 24 hours on the clock. So the patient sets their alarm on their phone, 9 o'clock every morning, as soon as they wake up, whatever time it is, they have their pill. If it's more than 3 hours, it's considered late and therefore ineffective. So they would have to use other precautions. There's the newer generation pills have got a longer window of safety there, up to 12 hours for the desogestrel. Drospirenone has got more than 24 hours. With typical use, the mini pill has got approximately 9% risk of pregnancy. Perfect use, less than 1%. And that's setting your alarm, taking it on the time where we're not extending those hours out. There's limited evidence on the effectiveness of significant differences in effectiveness between the traditional POPs and the DSGs as well. So they're kind of all about the same. Vomiting may reduce the effectiveness if that's within a few hours of taking the pill. And the body weight, there's no impact on effectiveness for higher BMIs. So special considerations of the POPs: double dose POPs not required for individuals overweight or with obesity, and there's insufficient evidence to determine if bariatric surgery affects the POP effectiveness. But extrapolating that data out, it may be, we might have to think about applying the same thing to the combined hormonal contraceptive, is that the absorption may be altered with bariatric surgery. So it's just something to keep in mind, and possibly we'll have more information coming out on that we can refer to. Users may consider non-oral contraception for effective post-surgery contraception as well. After surgery, we might have to have some other barrier contraception if we're having some surgery. The POPs can be used for medically eligible, that's individuals with no contraindications, between all the way from menarche right up to age 55. And our contraindications, which we'll refer to our UK MEC 3 or 4, we want to stay away from them. Contraindications: breast cancer, previous arterial thromboembolism during POP use, and cirrhosis, hepatocellular tumours as well. So with the POPs, there's no significant increase in thromboembolism risk. There's a small increase in breast cancer risk with current recent use, and an absolute risk is very low and returns to baseline after we finish using that. There's no confirmed causal relationship between POP use and depression or headache. So the mood disturbances hasn't been linked, and there's no clear evidence linking the POPs to acne. Users may, however, experience some weight gain, but evidence does not confirm significant causation. So the theory that I've put on all of this weight because of the pill, it's probably not the pill that's done the weight gain. There'll be other factors. When do we start the pill? So we've decided it's safe for us to take the mini pill or the POP. When are we going to start that? So traditionally, with the traditional POPs and the DSG, you can start on day 1 to 5 of the menstrual cycle, or you can start by day 5 after abortion, or by day 21 after childbirth with no additional precautions. At other times, you can quick start with 2 days of additional precautions and follow-up pregnancy test if required, if needed. Drospirenone, starting that one on day 1 of the menstrual cycle, day 1 after abortion, or day 21 for immediate effectiveness. If started later, we need 7 days of additional precautions, and that's comparing that to the 2 days that we need with the traditional and the DSG POP. Post-pregnancy use, progestogen-only methods have no adverse effect on lactation, infant growth, or development. So that's quite safe to take. So in our summary of our progestogen-only pills, we've got UK MECs for that, and you can see the biggest UK MEC on for the progestogen-only pills is the current breast cancer. So any decisions with contraception and breast cancer would need to be made with a specialist, and generally keeping clear from that UK MEC 4. So moving on from our mini pills and on to progestogen only implants. So this is our Implanons that we have in Australia. That's our trade name in Australia. First year failure rate is 0.05%, although rare cases of true failure is reported. The risk of pregnancy in the 4th year is very low. However, routine use beyond 3 years is not recommended. So the studies have shown us that even if that Implanon is left past the recommended 3-year time frame, pregnancy is still quite low, and there's no link between BMI and failure risk. So drug interactions with the Implanon, the effectiveness may be reduced during the use of enzyme-inducing drugs and for 28 days after stopping. So this is similar to our combined hormonal contraception. Similar classes of drugs as well that may reduce the effectiveness of that implant. So there's special cases such as short-term enzyme inducer use, and short-term is less than 2 months. We'd continue the existing contraception using an additional reliable method, barrier protection, and also for 28 days after stopping that enzyme inducer medication. Long-term enzyme inducer medication, carbamazepine, phenytoin, offer methods unaffected, and that would be, other options would be your IUD, so Mirena, and also the depot injection. We'll get to the depot injection later on. So who can use the Implanon? It's suitable for medically eligible individuals all the way from menarche to age 55. There's no limit on consecutive implant use. So in theory, a patient can use it every 3 years and just have it changed over, taken out, put back in the same spot, every 3-year cycle. The UK MEC 3 and 4 for Implanons, breast cancer, VTE, decompensated cirrhosis, and unexplained vaginal bleeding. we want to investigate that vaginal bleeding before we actually go ahead and use the Implanon. So benefits of the Implanon: dysmenorrhea. Most individuals will experience improvement in baseline dysmenorrhea. A few report new onset or worsening symptoms, especially after initial insertion. Heavy menstrual bleeding. Evidence is insufficient to draw conclusions on Implanon's effect on heavy menstrual bleeding. In theory, in practice, it can make it lighter. It does take a little while, possibly up to the first 3 to 6 months, to really work out if the Implanon is going to be effective on heavy menstrual bleeding. There's limited evidence to suggest that there's potential improvement within the first year of use on endometriosis-associated pain. So endometriosis is not a contraindication for using Implanon. You can use that as well. Adverse effects of the Implanon. There's no significant increase in risk of venous or arterial thromboembolic events with an Implanon. There's limited evidence, but no clear link with reduction in bone density. And cancer risk, there is a possible small increase in breast cancer risk with recurrent hormonal contraceptive use. The absolute risk remains very low. There's no conclusive evidence linking Implanon to ovarian, endometrial, or cervical cancer. Ectopic pregnancy, the risk is extremely small, but still something to consider if you did have a positive pregnancy test with an Implanon. So in terms of bleeding pattern, this is always a bit of a contentious issue in practice, is getting the patient through that first 3 months of having their first Implanon. You can have irregular, unpredictable bleeding initially. However, over time, that generally settles. So when we go to put an Implanon in, often I tell patients that we need to, in the first little while, expect changes in bleeding patterns. The bleeding can be unpredictable and may vary. And also, if it is a problem for them, we want to know about it, because there's options that we can use, such as a 3-month trial of the pill. So we can use a combined oral contraceptive as well as the Implanon. That's quite safe to use. You can use mefenamic acid for 5 days as well, and tranexamic acid while the patient is having their first few days of the period. In some cases, it has to come out because the patient just can't stand it, doesn't like it. That's fine. The Implanon is fantastic for being able to be put in and taken out in a general practice setting anyway. So it's quite easy and good if the patient is not really sure about it, because it's totally reversible. Adverse effects. Headaches are commonly reported, but there's no confirmed causal association. Acne, once again, that's some experience new or worsening, others report improvement. So the jury's kind of out on the acne side of things with Implanon. Depression, mood changes, once again, the evidence is too limited to confirm or exclude a causal link. Weight gain, same thing, no definitive evidence. So often patients will come saying, oh, you know, it's all over the internet. I saw my friend, they did this, they did that. Often what happens, despite the evidence, is that patients start the Implanon in that later adolescence, when they're transitioning from possibly a higher sporting active schooling to more of a sedentary role, and they were going to gain weight anyway. It's just so happened that coincidentally they had the Implanon inserted around about the same time. So, but yeah, there's no definite evidence to say that it causes weight gain. The rare complications, which I'm sure you have all heard about, is the local migration and rare cases of intravascular insertion. The one that I have heard about was or patient told me about, was the Implanon that ended up in a patient's lung. I can't comment on that. It's just what I heard about, but it's rare, can happen. That's why if you're using things like the Implanon, it's advisable to do the training for insertion. So it's quite a short training process, and the devices are made so that you can actually, you can't really insert it too deeply. And obviously you palpate after insertion as well. So if you have an impalpable implant, so patient says, I have got an implant on, but I don't know where it's gone. So we're not going to attempt removal without finding out where it is first. So that's where we need to do ultrasound, X-ray, something like that to at least find out where it is. If it is just not where the patient thought, still in the arm, but not in the precise area, you can go ahead and remove that. However, if it's deeply sited, it should come out with specialist intervention. And we also probably should be thinking about alternative contraceptive options as well, because it may not have been as effective, so the effectiveness may be reduced. Our summary on our implant-ons, once again, we refer to our UK MEC, and you can see there the breast cancer as well, mainly because it's progestogen. That's the medication we're using. So if we can steer clear of that, it's pretty much a UK MEC 2 to 3 for everything else. So in terms of the progestogen injection, so we'll be moving through now to a depot, and our effectiveness of the progestogen only injectable contraception failure rate is approximately 0.2% in the first year. Typical use is approximately 6%, and that's mostly because we've had an extended period of time in between our injections. So we have a few different brand names on the market here in Australia. Long-acting, we've got Depo-Provera or Depo-Relavera, which is 150 milligrams in 1 ml, and we'd be injecting that every 13 weeks, preferred into the gluteal muscle. Alternative, mostly simple enough for a patient into the deltoid. And the main drawback with that is having to have the injection every 13 weeks. So either with a nurse practitioner, GP, whatever it may be in your location in terms of doing those injections. So the depot efficiency or efficacy is not reduced with concurrent use of the enzyme-inducing drugs. So that's a good option to be using if the patient is having to have those medications long-term. Interaction with UPA, which is one of our emergency contraceptives, and we'll get to that later on into a little bit more detail. But in terms of the effectiveness, the effectiveness of the emergency contraception may decrease if we have that injection within 5 days. So that's something to think about. We should delay starting the injection for 5 days and use additional contraception for 7 days. There's no increased pregnancy risk in higher weight users, but there's limited data for BMIs over 40. And for individuals with deep gluteal adipose tissue, we might have to think about shifting that to a deltoid administration. So in terms of contraindications, the depot is UK MEC 3 for vascular disease, stroke, ischemic heart disease, unexplained vaginal bleeding. It's contraindicated in breast cancer. There's no restrictions for use in women with obesity. And it's a good idea to review every 2 years, according to the guidelines, to assess risk benefits and discuss osteoporosis risks. Alternative contraception recommended for women with osteoporosis risk factors. So we don't want to be making that osteoporosis risk any worse with a depot injection. So special age considerations for the depot. Under 18 years, it can be used after considering alternatives. So it is safe to use under 18. We just need to think about, do we really want to be using the depot long term in terms of our osteoporosis risk? So just making sure the patient is aware of other options, if there are other options for them, but also if that's all we have to use for them, maybe we look at monitoring osteoporosis with bone density scans anyway. 50 years and older, we'd like to switch to another method. but continuation can be considered with informed discussion of risks. Now, in terms of bleeding, generally most patients have no bleeding at all. So we have amenorrhea, and that often can help patients with their heavy menstrual bleeding, also gives them contraception. It may help reduce pain with endometriosis. The depot is not linked to increased risk of ovarian or endometrial cancer, and in fact may provide some protective effect. Interestingly, sickle cell disease, it's a suitable contraceptive option, and it may reduce the severity of sickle crisis pain. I did look that up, but because of the breadth of what we have to cover tonight, I didn't go into the detail of that on this webinar. But yeah, it's an interesting side point that that the sickle cell disease, it may benefit from depot injections. In terms of bone density, that's always linked to the depot as a possible contraindication. It's associated, the depot is associated with a small reversible loss due to the reduced estradiol levels. Breast cancer, a possible small increase in risk during current use. The risk returns to baseline 5 years after discontinuation. Cervical cancer, there's a weak association using the depot for longer than 5 years. That risk also decreases over time after stopping, and that may be influenced by other factors as well. So with our VTE, there's no demonstrated link between depot and venous thrombosis. There's limited evidence, but no confirmed link between the depot and myocardial infarction or stroke. Now, this also came up on the pre-webinar questions, was the risk of meningioma and brain tumors with the depot. So there's a small increased risk of meningioma with certain progestogens. And once again, the numbers are that small that I wasn't able to get a number on that. But I know that it has been in the media because patients have actually come in and asked about that. But once again, you'd be discussing the potential risks and benefits with the patients, but it's just something to be aware of so that it doesn't kind of catch you unawares. Bleeding changes with the depot, amenorrhea, you can have spotting, prolonged bleeding. If you do have some unscheduled bleeding that you want to manage, if the patient is eligible or medically eligible with no other contraindications, you can still use the pill with the depot, and mefenamic acid as well can be used up to 3 times daily for 5 days. Weight gain with the depot. So this does have some evidence behind it. It's more likely in women less than 18 years and with a BMI of greater than 30. There's an early gain of greater than 5% baseline weight in the first 6 months, and that is predictive of continued weight gain. So that might be something that we discuss with the patient, is the weight gain, risk of weight gain, but also the osteoporosis. They're the bigger issues with the depot. And in terms of side effects, the ones that have been reported include acne, libido changes, mood swings, headache, hot flushes, and vaginitis. You can also have the injection site reactions, so redness, swelling, infection, tenderness after your injection. And considering that you'll be having that every 13 weeks, it's something to definitely take into account. So with our next slide, we've got the when do you start that? Day 1 to 5 of the menstrual cycle. No additional contraception is needed. After day 5, you use additional contraception for 7 days. Quick start, use your bridging method. And post-pregnancy, you can use it. It's UK-MEC2 while breastfeeding, and you can start it immediately after the first or second trimester abortion. Now, in terms of if it's late, patients coming in too late to have it done, late injections can be given up to 7 days late without additional contraception. If the timing is unknown, administer it anyway. Advise additional contraception for 7 days. Fertility return is also an issue with the depot, so it may take up to 1 year to return after discontinuation. And women discontinuing the depot who do not wish to conceive should start an alternative contraceptive before the time or at the time of their next scheduled injection, even if they're having no periods. Special considerations: epilepsy, women on long-term anti-epileptic drugs with limited sun exposure are at increased risk of osteoporosis. So the NICE recommends vitamin D supplements. Women with HIV may have lower bone density and osteopenia due to multifactorial causes. Antiretroviral therapy can cause bone density loss, and we'd want to think about that bone density impact when talking about or selecting contraception. Learning disabilities. So the depot is often used to manage anticonvulsant related effects or reduce menstrual bleeding, and that discussion should evaluate all the options and consider the individual's decision-making capacity as well. It can be a really useful contraceptive, and also managing periods for that population. So our summary for depot injections, once again, we've got a UK MEC that's available in the guidelines to refer to, and that's always such a great tool in terms of working out what's ideal for the patient. So moving on to barrier methods. So we've got the efficacy for pregnancy prevention. Male condoms, 98% effective with perfect use. Female condoms, 95%. Spermicides are not recommended alone, and in fact, they may increase STI HIV risk according to the guidelines. In terms of STI prevention, condoms are the most effective method when used consistently and correctly. Diaphragm, cervical cap, limited evidence for STI prevention. And the diaphragm is to be inserted any time before intercourse and not to be removed until at least 6 hours after the last intercourse. We need to be mindful of STI testing, providing information on testing, HIV, syphilis. There's DAMs that are also available for reducing STI risk during oral intercourse and oral sex, and there's emergency contraception HIV post-exposure prophylaxis if we have breakage of that barrier method. So the factors that affect the efficacy: lubricant use. So we want to only use water or silicone, and we also want to use lubricant to reduce the condom breakage during anal sex as well. Condom safety: don't add the lubricant inside condoms. Some patients think that that's how you use it. It's not. Ill-fitting condoms, that can also reduce the efficacy, and thicker condoms are not necessary for anal sex, and the breakage rates are similar for standard or thicker condoms. So in terms of HIV, STI prevention, you have to respect your health, your legal issues and your local rules in terms of STI notification, transmission, advising partners, post-exposure prophylaxis. Patients should be informed about their PIP for PEP for HIV after a potential exposure, and that depends on risk assessment. So that's probably more to do with sexual health and a whole nother sideline, but it does make a mention within the guidelines as well. Emergency contraception supply was covered in the guidelines in terms of if you're relying on barrier contraception, barrier methods, do we have an emergency contraception? It can be considered, although routine provision is not supported by evidence. So if patients are wanting an emergency, like an advanced supply of emergency contraception, that's fine, but it's not supported by any evidence. Just tell me how we're going for time, Campbell, if we need to wrap it up, but it'll get a bit faster soon. So special considerations with barrier methods: HIV, latex sensitivity, and toxic shock syndrome. So one thing to note with our barrier methods is that it's UK MEC 3 for diaphragm and cervical caps, and make sure they always look at the manufacturer timelines and avoid use during menstruation. So summary for our barrier methods, you can see it's mostly UK MEC 1 to 2. So most people can use that, and it can be used in combination with other options as well. So moving through to fertility awareness methods and how we would use these. So a trained practitioner should ideally be using our fertility awareness methods. There's a few different methods that can be used, and the effectiveness is increased if you combine multiple indicators than just relying on one indicator alone. There's a couple of different methods there that's listed. You can rely on cervical secretions, the symptothermal method. We won't go through all of them, but just be aware that there's different indicators that patients can use to see or to monitor their fertility and to be more sexually active on different times than others, and to use barrier methods if they require. So barrier methods can be used during the fertile window as an alternative to abstinence, but with a higher failure rate, especially during ovulation. And now, fertility indicators alone are not sufficient for women using teratogenic drugs. So we really want to have some contraception with a higher effectiveness. High risk pregnancy. And fertility indicators are not recommended if pregnancy poses a significant health risk. So same thing, we want something that has a higher effectiveness. In summary, with our fertility awareness, in the guidelines, it's got great diagrams in terms of lactational amenorrhea method on the left there. And you can see on the right, there is an excellent chart that covers a few different indicators and how they can be used in terms of tracking fertility. So moving through to quick start contraception. So this is if we need to start it now, we're not monitoring any cycles. Any contraception can be quick started if it's reasonably certain that we don't have a pregnancy on board or at risk from an unprotected sexual intercourse. So how do we do that? Negative pregnancy tests don't exclude pregnancy until greater than 21 days after the last episode of sexual intercourse. Emergency contraception may be indicated in that time while we're waiting for that 21 days. So we do pregnancy tests initially and then at 21 days to make sure we haven't missed an early conception. Method-specific recommendations. So the combined pill, Implanon, and the progesterone only can be quick started if preferred. The depot, consider other methods. Consider if other methods are unsuitable. So because that would have a longer onset. The Implanon and Ciproterone combined hormonal contraception, avoid quick start unless pregnancy is excluded. Copper IUD is only to be used as a quick start for emergency contraception. So we'll get to that in the next section. So post-emergency contraception quick start, these we'll discuss later as well. We've got two forms of emergency contraception. So that's like the morning after pill. We'll talk about those two different arms of that in the next section. But you can, after the LNG, you can quick start the combined hormonal pill, the POP, the Implanon, and the depot immediately. After the UPA, we'd be waiting 5 days before starting hormonal contraception, using barrier methods in between, and then also making sure that we repeat our pregnancy test 21 days after. So if we have unavailable inappropriate methods, we offer a bridging method that can be quick started. So for example, you could use the pill while you wait for the depot to become effective. If the pregnancy has been diagnosed after quick start, no harm to fetus is associated with the contraceptive hormones. Termination is not recommended. If we're going to continue that pregnancy, we need to stop or remove the contraceptive if they wish to continue that pregnancy. After an abortion, Implanon or depot users, they can continue contraception with no additional precautions. The pill or POP users stop the current method, restart immediately after the abortion with no additional precautions. There's a slightly higher risk of failed abortion with continued use of depot as well. So there's also a good summary to exclude pregnancy in the guidelines as well. So there's lots of different information that you can access with that. So emergency contraception. So this is where we'll talk about the two different sorts of emergency contraception that we have available here in Australia anyway. When to offer emergency contraception. After any unprotected sexual intercourse, any day in a menstrual cycle from day 21 postpartum, from day 5 after abortion, miscarriage, ectopic pregnancy, if regular contraception has failed or been used incorrectly. Emergency contraception options. We have the copper IUD, which is most effective, and it can be inserted up to 5 days after either unprotected intercourse or ovulation, whichever is later. We've got Ilipristal, so that's known as Ella, and that's effective up to 120 hours after intercourse, and that's more effective than the levonorgestrel, which is only licensed for use up to 72 hours after UPSI as well. So oral emergency contraception after ovulation, evidence suggests it's ineffective. So we need to work out how we're going to manage that and how we can kind of time the ovulation. But that's why we would be planning for ongoing contraception, as well as making sure that we're check that we don't have a pregnancy while we're using that. So once again, with emergency contraception, we have the effectiveness isn't affected by weight or BMI. Oral emergency contraception, higher weight or BMI may reduce the effectiveness, especially for the levonorgestrel. And so for individuals with a higher weight, you might want to double that dose of the LNG. And also with the enzyme-inducing drugs, the effectiveness may be reduced. So we need to just always counsel our patients in terms of what to expect with that. So there's a couple of special considerations. The Ilipristal isn't suitable for women with asthma, which is controlled by oral glucocorticoids, and the effectiveness can be reduced if the progestogen is taken within 5 days after the Ilipristal or within 7 days before taking the Ilipristal. No need to interrupt, but it's a good idea to minimize exposure, express and discard breast milk for 24 hours after using the Ilipristal emergency contraception. So enzyme-inducing drugs also, we might want to increase the dose. Effectiveness is unknown, and the levonorgestrel is safe during breastfeeding with no adverse effects on the infants. A copper IUD is recommended for women on enzyme-inducing drugs. Contraindications are the same as for routine insertion. Slightly higher risk of uterine perforation with a copper IUD, but the absolute risk is still low. We don't need to double the emergency contraceptive dose of the Ilipristal with enzyme-inducing drugs either. So use of the emergency contraception in the same cycle. So can you use it back to back? Yes, you can. It can be offered again after a further episode of unprotected sexual intercourse in the same cycle. Neither the Ilipristal or levonorgestrel disrupts an existing pregnancy or causes fetal abnormalities. Interactions between the emergency contraception methods, yes, there are interactions. You can see how complex it is there. If that's a consideration, I suggest going back to the guidelines and reading through, working out what's going to be the best for that patient. Probably one of the best emergency contraceptives is the copper IUD because it provides ongoing effective contraception. So in terms of planning forward, copper IUD, effective ongoing contraception. Oral emergency contraception obviously doesn't provide ongoing contraception. We want to start hormonal contraception immediately after an emergency contraception use. And we just want to make sure that we get our cycles correct in terms of the ovulation there to see whether or not it's a problem or not. The guideline also gives us good summaries in terms of decision making for the emergency contraception and which one to use in terms of timeframes. So they're excellent guides to work through that as well. Finally, tubal ligation and vasectomy. So tubal occlusion, cancer risks, we've got ovarian cancer. The tubal occlusion may provide a protective effect over time. Breast, cervical, endometrial cancer, no evidence of increased risk. No changes in hormone levels post-procedure. And there's an increased risk of hysterectomy observed with tubal ligation or tubal occlusion, but no causal link established. Women report worsening menstrual symptoms, but evidence doesn't report causation, doesn't suggest causation. Fallopian tube reanastomosis can restore the patency, but it may not guarantee fertility or pregnancy. The Eshore, I'm not sure if that's still available in Australia. I don't think it is. Reversal is not possible. IVF is the only alternative with that one. Vasectomy, pregnancy risk is 1 in 2,000, and that's after clearance to make sure that we have had a successful vasectomy, a successful procedure. Failures can occur several years post-vasectomy. Post-op pain, there's a risk of testicular, scrotal, penile, lower abdo pain, and there's also a risk of a chronic post-vasectomy pain. No increased risk of testicular cancer and there's a very weak link with prostatic cancer. So let's move through to our case study. Madeline, she is our 15-year-old female attending local high school. She's a high academic achiever playing sports. She comes to us with heavy, irregular periods. What are our options for Madeline? So she's come with her mum, and we have a discussion which includes her risk of VTE. She's got a background of migraine headaches with no aura. It's decided that they're both happy for her to try the pill as a starter to see if that will manage her heavy irregular periods. So working through our UK MEC, we can see that she doesn't have an aura, so she's UK MEC 2, which is quite safe for her to start the pill. We've also got our next slide with Madeline showing that she is being reviewed at her 3 months. Periods have improved. She's happy to continue that. The periods are more predictable and lighter. She's happy to continue with the pill for the time being anyway. Next time we see Madeline, she comes in at 16.5. She's by herself, telling us that she now has a boyfriend, Tom. She wants to have a chat about contraception. So what are Madeline's options with contraception? We explained to her that her current combined hormonal contraception that's being used to manage her heavy irregular periods is 99.5% effective. So in real life, it can be less effective if pills are forgotten. And we remind Madeline that she also needs to protect herself against STIs with barrier protection. So Madeline's happy with that, moves through high school. She's now 19, attending university, and she has not been taking her pill regularly. She's had the condom broke 2 nights ago and emergency contraception is required. What do we offer for Madeline? So her options, she can have an oral medication, either the Ulipristal or levonorgestrel, or a copper IUD as emergency contraception. So we walk through our decision-making algorithm with Madeline, and she weighs everything up. She's very scared from the experience, and she's interested in a long-acting reversible contraception. She settles on a copper IUD as emergency contraception, ongoing contraception. This suits her. She's planning to travel, finish her degree, and it can be used for 5 years. So she's quite happy with that. 24 years is when we next see Madeline. She's finished her degree, working as an accountant. She's now married to Tom. They want to remove the copper IUD to start a family. So the GP can quite easily remove that copper IUD in the clinic. 12 months later, Madeline presents for her postnatal checkup. She's had her first baby, she's breastfeeding. So what are her contraceptive options now? So looking back at Madeline's history, what is available for her is a wide and varied selection of contraception options with her breastfeeding. And they choose, or she chooses, to have the Implanon implant inserted, and we can do that in the practice. Madeline goes through to have 2 more children using her Implanon in between pregnancies. She's now age 32. Periods are heavy and irregular, and she's iron deficient because of her heavy periods. So working through with Madeline, we have options. She can either remove the Implanon, go for barrier protection versus having the pill versus depot injection versus a Mirena. She can keep the Implanon. She can add the pill. There's lots of options that Madeline can use in this situation. Obviously, we investigate why she's bleeding heavily and make sure that there's no problems there. So she actually decides to go to a gynecologist for further information and see what other options, if any, may be available, and also for those further investigations. So she settles on a hysteroscopy, dilatation and curette and insertion of a Mirena. So this now puts Madeline at, it lasts for 8 years, takes her up to age 40. So at 40, she has a changeover Mirena in the GP clinic with an appropriately changed GP. And that Mirena will now take her through to 48 years of age. The decision point with removing her Mirena, as it's coming to the end of its life, so she's had it for her 8 years. Does she leave it in and add additional contraception until 52? Does she change the Mirena over? So this is another decision point for Madeline to have with her GP. And she decides that she wants to change her Mirena over, as it will provide ongoing contraception, endometrial protection if she does decide to use hormone replacement therapy, and it can also control heavy menstrual bleeding and therefore iron deficiency anemia. So you can see that with a lifespan case study such as Madeline's, there's decision points along the way. We need to be having comprehensive discussions and information that we provide to the patient. There's no one size fits all. There's definitely no one is better than the other. And you can see from the breadth of information that's covered in a webinar such as this, in terms of like the updates with contraception, how much information is available, and also how you can't know it all. You need to, refer to guidelines, especially for certain situations. So the choices are dependent on life stages, personal choices, what's available in your locales, and also taking into account options to minimize risks. So I think that wraps up our webinar for this evening. That's our references.
Wonderful. Well, thank you so much, Dr. Simone, for your insightful presentation. There certainly was a lot of ground covered. There's quite a few questions that have come in.
There was a couple regarding the meningioma risk and the depot. As far as I know, there is a lawsuit around, or a case, a class action being developed by, or being, started by some lawyers. I'm not over all of that, but I know all, so long as we're aware of it and we make patients that are aware of that as a risk with the depot, the risk is very small though. So that did come through in some of them.
We've got here, in a case of a recurrent history of ectopic pregnancies, for instance, there's 2 to 3 successive episodes following IUC use, would it still be ideal to go on to insert another?
For Mirena, yes, you could still insert another one. Some patients, we're trying to prevent a pregnancy, so it would be kind of unlikely that we would be having that many ectopic pregnancies with the Mirena. but there's no contraindication to inserting another Mirena after having that many, or even having a previous history of ectopic pregnancies without having the Mirena. So if the ectopic pregnancies were encountered prior to the use of Mirena, yes, it is safe to still go ahead and use the Mirena. It would be highly unlikely to have an ectopic pregnancy while the Mirena is in situ, but it's not a contraindication to deal with that ectopic pregnancy and reinsert another Mirena.
Okay, great. We've got a question here. If on Mirena or Implanon and they're experiencing heavy bleeding, and then we go ahead and trial 3 months of COCP, should we skip sugar pills or not?
Totally up to the patient. In my practice, I tend to, especially in a situation like that, I would be not skipping the sugar pills, so having them so that we don't have that sort of murky area of, are we having breakthrough bleeding? I would just like to see a normal cycle for 3 months and see how that goes. And we say minimum of 3 months. So the patient can use both therapies for long, if they need to, for long term. So, and then once they get the hang of it, if we've settled that heavy bleeding down, we could then start to skip the periods.
Okay, great. Got a couple of questions around progesterone and the risk factors for VTE. And so one person's writing that they thought that all progesterone was safe, and another one, which progesterone are high risk for VTE? Any names? Can you speak to that?
Oh, so for VTE, there's a very, very low risk with the progestogen only pill. So the mini pill, there's a low risk, but that still has to be taken into account with the patient's history. And that's things like here in Australia, we've got Microlute that we would be using in that case, and that would be the traditional one, the POP. And that gives us a much lower risk of VTE.
Okay, great. We've got an interesting one here. It's a little bit longer. So if a patient on any form of contraceptives develops some features of perimenopause, should you stop contraceptives to check if she is really going towards menopause? Or what's the best practice to avoid confusion about when she has attained menopause? Can you speak to that at all?
That's a really tricky situation, and also very patient focused, because even if we are going through perimenopause, the patient may still want to be having contraception. So if you want to stop the contraception, you basically need to stop the pill for 6 weeks to see if we can do blood markers on there, to then see if we're achieving menopause or around menopause, and then work out what we're going to do. However, if we're doing that and we still want contraception, we need to look at barrier methods as well. So that can be a little bit tricky. Alternatively, we can just keep going with the contraception and try and make a clinical diagnosis in terms of menopause, bearing in mind that some things like Mirena and even the pill can be used as a HRT. And it also depends on the symptoms, the problematic symptoms for the patient that they think are attributable to menopause. So I suppose in summary for that question, Campbell, if we're looking at menopause, we like to treat, or prefer to treat, the symptoms of menopause rather than the diagnosis of menopause. And there's different treatments for different menopausal symptoms that may or may not be hormonal in nature.
Okay, great. I think we've got time for just a couple of more questions here. Someone writes, can we give Depo-Provera to a patient with a family history of osteoporosis?
Yes, you can.
Excellent. that gets to the nub of it?
Yes. Yes, you can, with the all the same indicators as you would with any other patient, watching the length, the age, all of that sort of thing. But family history of osteoporosis is not a contraindication.
Okay, great. And Rochelle writes, this is just following up on something that we were just talking about with progestogens and VTE. Do you know how the small increased risk of VTE for progestogens compares with the increased risk in COCP? And does the guidelines, or are there some references that they can go to that you mentioned anywhere in your talk?
Yeah, definitely. On the slide there, the guidelines actually state all of those risks, and they get right down to the nitty-gritty of all of that. And they also direct you to other areas and other studies that help make that decision-making process a little bit easier. So yeah, definitely into the guidelines, plenty of information in there. And as I said, it's a signposting thing, so it's a collection of data and information. No one can possibly memorize everything that's in there, but it's just a terrific reference point. And tonight I've just picked out a few different things that I thought might make people a bit more aware of what information is available to help make those decisions.
Well, wonderful. And with that, that'll draw to a conclusion tonight's webinar. If you're interested in self-reporting tonight's webinar, or see, there'll be some information about that as well. And once again, thank everyone for taking time to watch the webinar this evening, and certainly everyone join with me in thanking Dr. Simone Gonzo for taking time out of her week and busy schedule to present all the information to us this evening.
Not a problem. Thanks, Campbell. Thanks, everybody.
Excellent. Thanks again, and have a good night.